Yeah. So one day it'll be the next snorkel, the Avalon Cannula, I tell you. We'll be surfing into our 150s. Okay, so what I'm going to talk to you about is the insertion that we use for retrievals, which is basically a single operator insertion. So I do the toe and I put the thing in at the same time. Sounds tricky? Not so tricky. Yeah, you have to, there's certain things you have to do to make it safe, and I'll go over that. So the two big problems with Vb Ecmo are what? Okay, first one is that you need high flows. And why do you need high flows? Well, if you had a perfect world, you could get all the patient's cardiac output through the ECMO and put it back into the venous circulation, and it would all be oxygenated. But we don't have a perfect world. The only way to do that would be to put the ECMO circuit in the pulmonary artery. Can't do that at the moment. So there's always a portion of the cardiac output that does not go through the ECMO circuit. So the resultant arterial saturation over here is always disappointingly much less than what's coming out of the oxygenator. And we do know that you need to get about 2/3 of the cardiac output into the ECMO circuit to get arterial saturations of that order, that's all right actually, but seems disappointing. So if you've got 6 litres a minute of cardiac output, you need at least 4 litres of ECMO flow to get those sort of saturations, 85 to 90. But if it's 10 litres a minute, if the patient's septic or if somebody pokes them with something, you know, ECMO patients are always asleep and then they wake up because of some reason. Somebody puts an X-ray board under their back and, you know, first thing in the morning in the ICU. What happens is they desaturate because their cardiac output goes up and you haven't increased the amount of blood you're capturing in the ECMO circuit. But if it's 10 litres a minute, you need 6 to 7 litres a minute. That's hard to get with standard cannulation, but you can, in some patients, get it with an Avalon cannula. Okay, so what can you do? Well, Josh mentioned if you're trying to get more flow, you can put an extravenous drainage cannula in the neck. Good thought. But there is a problem. Because of where it is, what you do is you cause recirculation or more recirculation. So the higher you turn up the flows, the more recirculation you get. The reason for that is, even though you get higher flow from the ECMO, so the blood coming out of the ECMO circuit that's oxygenated has higher velocity, you also have greater suction. And if the two cannulas are close together, all you're doing is sucking it straight back into the circuit. So there's a funny point where you turn the flows up higher and you may actually desaturate because you're getting more recirculation. And this is just a modified bicable view of sort of recirculation. The tricuspid valves here, that's this is sort of, it's SVC, that's RA. And this is a venous drainage cannula just below the RA-IVC junction. So most of the flow when the tricuspid valve is open is going across there, but when it closes, all of it's going up to the drainage cannula that we've got in the neck. So you can try a different configuration. You can drop these a bit lower from the heart, and you can put the return cannula in the SVC-RA junction. That's not a bad circuit. If you can't put an Avalon in, that's the next best thing. But it's still not the Avalon. So what are the advantages? It's big. So we use 27-31 French cannulas. So that one's a 27, that's a 31. So they're big mothers. That's for adults. They're bi-cable, so they've got drainage holes at the end for the IVC and drainage holes here for the SVC, and they've got that return port there, which is a second port, so it's dual lumen, and that you've got to point at the tricuspid valve. But the other advantage of it is you can potentially just have one single site insertion, which is in the neck, so you can sit the patient up. And this is just a video of it going, well, not a video, an animation of it going in. So the important thing to notice there, see the arterial limb, which is this one, the return limb, it's got to be pointing towards the ceiling. If it's pointing that way, the return port moves with it, it's going to be going the wrong way. And in fact, to get it to sit like that, so the blood's going from there across the tricuspid valve. This thing has to be sitting like that and pointing towards the ceiling and then pointing towards the nose just a little bit. If it flips over, it's all over. So these cannulas require commitment. Okay, you can put it in. If you don't secure it well enough to stop it flipping over, you might as well have not have, put it in. Sure enough, it'll be 2 o'clock in the morning and some nurse will be trying to tidy up stuff around the patient, tidying up the ECMO lines, and it'll flip the cannula over if you haven't secured it well enough. And they'll desaturate. They'll ring you and say, "Oh, I don't know what's going on." Okay. So how good is it? This woman is 200 kilos. She had swine flu. This was Lismore. We were in Sydney, went to get her in Lismore. I thought, it won't work. Well, that was her x-ray. It worked. It was perfect. In fact, the biggest problem was getting her back to Sydney. A lot of people scratching their heads about how we're going to do it. Anyway, we couldn't do it by plane or road. We used a helicopter, but even then we had to stop a couple of times because of fuel, because of the weight issues. Anyway, that was her 3 weeks down the track. She did very well. This is another patient, pre-transplant, woman 42 with a fibrotic lung disease, pre-lung transplant. And they're so good, they can allow you to extubate some patients on the ECMO. So she's awake, extubated. So Jackie, can you just tell me if you feel breathless at the moment? No, just tired. Are you reasonably comfortable with, with that thing at the side of your neck there? No. She said no. Not comfortable. Not comfortable. Anyway, that was her x-ray, so no wonder she wasn't comfortable. But there's no endotracheal tube there and there's no lungs. So pretty good, huh? Anyway, that was a couple of days later. How do you feel now? I had a cue card. Great. So, and she got to transplantation about 2 weeks after that, and that's her a year down the track, so she did very well, especially being older. They're good for the long haul. So this is a 12-year-old that we looked after with the Kids Hospital in Sydney, cystic fibrotic, awaiting transplantation. Intubated, couldn't ventilate her, put her on to ECMO using an Avalon cannula. She had that thing in for 54 days before she got transplanted. She was so small we had to wait for appropriate sized lungs. That's her about 6 weeks after she got discharged from hospital. She's in hospital about 5 months, the poor thing, but not looking too bad. That's about 18 months later. She got some Premier's Award for bravery, which is pretty good, but she looks fantastic. And she was actually singing at the Sydney Opera House 2 years after the transplant. She was actually intubated for 70 days. That's better than I can sing, and I haven't ever been intubated. Anyway, so that's how good they are. Long haul, you can have them in for a long time and they can function very, very well. But we use them on retrieval. This is a long haul retrieval, talking about long haul. This is a kid I picked, 15-year-old kid, picked up from Noumea with good pastures. So what do we do? How do we do it? That all looks a bit messy there. But it's just basically me. I use somebody to help me, feed the wires in and pass me a dilator, but it's basically just me doing it. So we put the tow probe down. We've got a portable sonosite echo machine with a tow attachment. So we've got a portable tow probe. We put that down first, make sure we can get the echo pictures we need for it, and then put the drapes on, make sure we can still get the pictures with the drapes on, and then go for it. So what do you need besides that? You need Avalon cannulas. We usually take a few of different sizes, usually the 31 and the 27. You need the introducer kit that Avalon provide, which is one of these. Have a look at those dilators. They're quite nice. They go over the wires well. But for a 31 French, the biggest dilators are 30. Not good enough. So you get a bit of a problem putting it in because the hole's not big enough. One way around is you just push it right into the hilt. And sometimes you've got to make a bigger cut in the neck, and if it just won't go in, we put the smaller cannula in. A 27 French, no problem with that kit. The second problem with the kit, that's the wire that comes with it. Feel that wire. What do you think of that wire? Good, bad? What do you think? Oh, you think that's stiff? Try this Viagra impregnated baby. That's a lot stiffer, right? So these are the ones that come with the kits. I'll show you the problem. Firstly, trying to manipulate this to go down the IVC, very hard because it's very thin and it's very flexible. Second problem is when you're trying to put the cannula over the top of the wire, I could do it for you, it kinks it. And it kinks such that the cannula wants to go into the right heart. And that's bad, because if you go through into the right heart, you are likely to go through the RV free wall and cause tamponade, which has happened, has killed patients. Putting these things in, that's bad. So what has happened, what we do is we use these stiffer wires. We use the extra stiff Amplatz wires. There's stiff, extra stiff, super stiff. Very simple. They're designed for cardiologists. That's why they're simple. That's why they're Viagra impregnated as well. Anyway, we use the extra stiff, works a treat. We also put in that little kit, that little sheath, so we've got control of the vein. So you need those two things extra. You need surface ultrasound to get access to the internal jugular, and you need the toe probe. The toe probe is crucial. If you can't get the views you need for this, we don't put in an Avalon. Okay, because if you muck it up, Paul Forrest had pictures like this. This is tamponade from rupturing the free wall of the RV. That's collapse of the right ventricle with a lot of blood around it. Not good. Anyway, we'll cut to the chase. Basically, it's very simple. All you need is this view, which is a bicable view. It's a mid-esophageal view. You just got to stick the probe into the esophagus and you'll almost get that view. So what is it about this view? That's SVC there, that's RA, that's IVC there, that's tricuspid valve, RV's here, LA's there, intraatrial septum. That's all you need. The way the thing goes, the wire's got to go that way and the cannula's got to go that way. That's all you need. It's very simple. If you can get that view, you're sweet. How do you get that view? Stick the probe in, mid-esophageal, you get the Mercedes-Benz sign of the aortic valve in short axis, which is about sort of 35 degrees. Then you swing around to get the long axis view of the left ventricular outflow tract, which is usually somewhere between 85 and 110 degrees. And then when you get that view, you just take the whole probe and clockwise rotate it a bit and it'll pop into view. Just like that. And Bob's your uncle. Now once you get that view, there's just one little added tip. In order to be able to see the whole passage of the wire in the cannula, you need to be able to move in from SVC RA to IVC. Now it's very simple. So to get the SVC, you pull the probe back a bit and you anti-clockwise rotate. To get into the IVC, you push the probe in a little bit and you clockwise rotate. All things you can do with drapes over the top of the probe. Okay, the steps. We put the toe probe down. We get that view. We think, sweet. Then we get access to the vein. We use surface ultrasound. You want to make sure the thing's in the right vessel. Okay, we then put the sheath down, so we've got control of the vein. Then we put the stiff wire in. And that's the wire going in. That's the slow-mo of the wire going in. Yep. How far down does it go? Right, so that's into the IVC, and that's further into the IVC, and we want it as far as possible. So usually till it stops, but it'll be past the liver. Because if it's not in very far, when you start dilating, it'll move. And anyway, so next step's dilating, and that's the tip. Over-dilate and keep an eye on that bloody wire. If it pops back into the RA, you've got to get it back down the IVC before you put that bloody thing in. If you've got a big hole in the neck already, not very nice. So keep an eye on it the whole time. We have our eyes on the echo and the thing like right in front of us. It's the only way, I tell you. So next step's putting the cannula in. This is always a bit scary. So my insertion tip, that's another joke. Tip of the cannula going in, insertion tip. Wasn't worth it, was it? Okay, so grab one of the cannulas. Somebody, a couple of you. So you see that there, that's the lead length. Yeah, grab it, grab all of it. So feel that and that. Run your hand up and down. That's not meant to be filthy. Just rub your hand up and down. They're very clean cannulas. So the lead length, before you get to the dual lumen part of it, that's just single lumen, this part here, that's skinnier than the rest of it. So in actual fact, for a 31 French cannula, it's 27 French, that lead length. So it's a bit of sort of like false security as you're putting the thing in, because you think it's all easy, and then you get to the return port and it can all come to a crashing halt. But what do you do then if it won't go in? There's two things you can do. One is you can pull the whole thing out and try and dilate again, make another nick in the skin, hope it's going to go in. Second thing you can do is just put the smaller size in, which is what we usually do. If you try and force that thing in, what will happen is it will tear something, or it will jump forward. If it jumps forward as you force it in, it will kink the wire, even the stiff wire, and it'll be in the RV before you know it, and the patient will die. So that's the cannula going in there, watching it on the echo, and you can see it there. That's in the liver, the IVC in the liver, and it's past the hepatic vein. And then I'm pulling the probe back up, anti-clockwise rotating, and I can see the return port on the echo, which is just there. And we usually check the position by flushing the return port. You can see bubbles coming out of the return port there. And that's it working. Okay, now, before you all run away, the other thing is, once you get it in, you think, balls of steel, it's in, I'm done, I'm out. Well, you're not a surgeon, you're a thinking physician. You've got to secure the thing so it won't move. Okay, if it moves, you will lose all the advantage of the cannula. So you have to connect the circuit up in such a way that it's not going to twist over, because the circuit's got torque in it, right? So you've got to unravel all the torque. See this here? This cannula is upside down. It's sitting like that. You know how it got like that? Because it's got lots of curling in the tubing, and a nurse was trying to tidy it all up, and she flipped it over in the process, and the patient was in trouble. So you go from being perfectly stable to being lots of recirculation, not much advantage of the cannula, and desaturating. It's very important. So when you put the tubing on, you got to twist the cannula towards yourself a bit and the tubing away, and that kind of hooks it in a bit. The next thing you got to do is you got to put something on the return limb so it can't flop over. So what we do is put a trachea tie which goes around the whole head. We put a knot around it there so that it sort of secures like that. If you try it, I forgot to bring trachea tie. If you secure it there, you cannot twist it over. Now, I'll just show you, that was meant to be another joke. That's that one upside down. Now, it was also too far in. So if it's too far in and it's twisted over, what's the point? So this is in the liver, and that's the flow from the return port. Sorry?
Okay, we're going to finish up now. 30 seconds.
Wait.
There's an arrested patient next door that needs all our help.
Okay, just 30 seconds. So if it's too far in and it's in a good position, it's still no good because you get a lot of recirculation. Now that cannula's upside down, but it was fair way back because he's a big guy, and it actually did work. So that's the return jet there, which is pointing towards the interatrial septum. So one tip about it is if it's high, it's not so bad. Still bad. But if it's in a good position and it just tilted over, it's still bad. I'm coming. Just give me 1 second. But that's good. And you've got to be committed to keeping them in that position. Okay.